Hello. I would like to start by saying thank you so much for the opportunity to speak at this wonderful meeting. And I'm also really happy to have followed Professor Saban's excellent talk, which is going to be very relevant to some of the things I'm saying and will actually modify some of the things I was going to say, I have to say. I first have to declare that my background is I'm an immunologist working on tropical diseases. I work at the Mahidol Oxford Tropical Medicine Research Unit here in Bangkok. For the last couple of years I've been based in Oxford in the UK, but coming back and forth a bit. But I spent several years living here in Bangkok and doing a weekly clinic at HIV-NAT. And during this time I became very interested in the diabetic population within the clinic, and that's who I'd like to talk about today. I would like to declare that I come from a background of being neither an expert in HIV nor an expert in diabetes. So I feel very fraudulent standing up today, but I was asked to speak, so here we go. I'm a bit worried about this opening sentence after the previous talk. So both HIV and diabetes have an association with adverse cardiovascular outcomes, premature aging, dementia, and early death. Now, this, of course, depends on reliable epidemiology and the quality of the control groups used. But we certainly see, as a population, people experiencing a lot of comorbidities. And both HIV and diabetes are characterized by chronic low-grade inflammation and oxidative stress. And because diabetes is common anyway, up to 7% of people in Thailand now have diabetes, then within your HIV population, you're going to have quite a few people with diabetes, particularly as they get older. And so this creates quite a lot of key questions, and in particular, we find that all the guidelines for diabetes are based on large studies in the West, in America, Western Europe, and they're not based on studies in people with HIV, and they're not based in populations in Asia. So some of the key questions for me are, does HIV and ART increase the risk of diabetes or not? What does the rise in diabetes in low and middle income countries mean for clinicians looking after people living with HIV? What treatment strategies, and that's both in terms of the HIV drugs and the diabetes drugs, are optimal, and that's particularly in low and middle income countries? And how does diabetes in people with HIV affect susceptibility to infections, which is a research interest of mine? So I'm going to briefly go through the epidemiology of diabetes in Thailand in particular, diabetes and infection, diabetes and HIV. Is it a risk factor? Is there an interaction between the two? I'm going to quickly look at current guidelines for those of us doing clinics, and what do we need to know? And just a little bit more background about how I came to be interested in diabetes in Thailand. I actually came out to Thailand to work on melioidosis, and if you ask Thai doctors about melioidosis, they know about it. If you ask Australian doctors, they know. Doctors in the UK often can't quite remember, and actually studies show about half of the general public in Thailand don't know about melioidosis, but it's a common bacterial infection affecting rice farmers, particularly in Assam province in the northeast where I was studying it. And what interests me is in the cohort we looked at in Thailand, 2/3 of all the patients coming into hospital with this devastating sepsis had diabetes, and about 1/3 of them died. And overall, various studies in Thailand have suggested that people with diabetes have a 12-fold increased risk of melioidosis in Thailand. So through this, I got interested in what is it about diabetes that makes people so uniquely susceptible. And at the same time, I was doing my weekly clinic at HIV-NAT, and I became very interested in the population here. So diabetes, as I'm sure you all know, is a serious lifelong health condition that occurs when the amount of glucose in the blood is too high. And it's a leading cause worldwide of cardiovascular disease, blindness, end-stage renal disease, amputations and hospitalizations. So a devastating disease. There are two main types of diabetes and other less common causes. I'm not going to talk very much about type 1 diabetes today. That's autoimmune disease, often arises in childhood but can arise at any age, and you need insulin right from the beginning. Probably about 5 to 10% of people with diabetes in the world have type 1, although it's often not very well characterized which sort of diabetes it is. What I'm going to focus on today is type 2 diabetes, which is where your body becomes relatively resistant to the insulin that you make, and that is associated with aging and obesity. So we really have an epidemic of diabetes. There's an estimated 422 million people now living with diabetes, and this continues to rise. 77% of people with diabetes in the world now live in low and middle income countries. So it used to be said it was a rich country disease, and now it's not. This map here, all the orange countries are Asia, and that's been one of the most accelerated increases in diabetes. So looking at the structure of the population in Thailand is interesting, bearing in mind that diabetes is associated with aging. So if you go back to 1950, there were about 20 million people living in Thailand, and you get this pyramid of a lot of babies and less in the population as you get older. By 1970, it was starting to change, 1990. And what I want you to watch is this bulge of population that's moving up. So here we are a few years ago, and here we are 2 years ago, and here's where we're going. So what this means is a big wave of people susceptible to diabetes is coming along. And thinking about the aging population and disease, looking at people aged 60 or over around the world, back in 2000, which wasn't that long ago, diabetes accounted for 16% of disease. And this is estimated 15 years later to be 21%. So the proportion of disease caused by diabetes is increasing. Diabetes in Thailand is increasing as well. And you can see the graph on the right showing the age distribution, so particularly people aged between 55 and 75. Another interesting thing about diabetes is the increased susceptibility to disease. So there's now good evidence that if you have diabetes, you're at increased risk of TB, probably around threefold. And if you have TB and diabetes, you've also got an increased risk of poor outcomes, such as increased risk of death and taking longer for your sputum to go negative again. So there's a real need for bidirectional screening in diabetes and TB. A large study in India found that if you go to a diabetic clinic and try to get them to screen for TB, it's very difficult and it doesn't happen very much. If you go to a TB clinic and try to get them to screen for diabetes, they're fantastic at it. And it's partly because screening for diabetes you can do by blood tests is more simple than screening for TB. And I think it's partly because in TB clinics they're very well versed in screening for HIV, so they can add on diabetes. Other infections and diabetes, there's a huge long list of increased risk. All clinicians are familiar with the fact that certain multifactorial syndromes such as foot infection, urine infections and surgical site infections are increased in diabetes. And also some bacterial infections like Staph aureus, Pseudomonas malignantotitis externa, Salmonella, and of course Burkholderia pseudomallei or melioidosis, which I've mentioned before. Some fungi. And looking at global infections, a lot of the studies simply haven't been done. And when they are, there are methodological flaws. There is probably an increased risk of dengue, worse outcomes in hepatitis B, hepatitis C, and zoster, and possibly malaria, but that really needs more study. There's a lot of immune changes which come along with diabetes. So when somebody has diabetes, it changes their ability to fight infection at every level. First of all, the high glucose may promote pathogen growth. Certainly in the lab, malaria grows better. You get a change in the commensals in your skin. different gut microbiota. Your neutrophils don't work so well. Phagocytosis is less good. T cells don't work so well. Changes in your antibody responses. And of particular interest is the chronic inflammation seen in diabetes caused by endothelial activation and an increased complement activation and oxidative stress. And you also get a disruption of cellular metabolism and enzyme function. A lot of your enzymes get glycated and just don't work so well. So you can see at every level diabetes affects your immune system. But on to HIV. Is HIV an independent risk factor for diabetes? Well, above all, the best studies have yet to be done, as far as I know. So quite often they're retrospective, they're not comparing like with like, as outlined in the previous talk. There was a large study, the Women's Interagency HIV study, suggested it wasn't a risk factor. Obviously that was just in women. And then there's a number of studies that have reported an association, and that's particularly with older ART regimes, which I've listed there, and one of them being a Taiwan study, which is the only big study in Asia until a recent one I'll talk about in a minute. Also worth noting that in the 90s we used a lot of pentamidine to treat PCP, which was associated with toxicity of the beta cells. And then last year, HIV-NAT published this lovely study looking at the 006 cohort, which goes back to 1996. And they were able to look back at people who, at the time of diagnosis of HIV, didn't have diabetes, and track them through the follow-up system and try to identify risk factors for developing diabetes. And so they identified 1748 people diagnosed with HIV who did not have diabetes at baseline, studied them for a median of 9 years, and found 123 of them developed diabetes. And in this cohort, the risk factors for developing diabetes compared to those who didn't, so it's a bit more like with like because it's within this cohort, were being older, which wasn't a surprise, male gender, increased BMI, family history, waist circumference, not a surprise, lipodystrophy, that's been reported in other studies, and particularly the use of didanosine, which we're not really using anymore. And comparing the people with HIV who had diabetes with those who don't have diabetes, as you might expect, they found higher mortality, higher cardiovascular disease and stroke, and higher renal disease. There's also an increased risk of certain factors that increase diabetes in the HIV population. So if you have HIV, you're more likely than the rest of the population to have hepatitis C, low testosterone, to use opiates, and to be on certain drug therapies, which all can increase your risk of diabetes. There's been a number of studies looking at the effect of ART on diabetes risk. Protease inhibitors, mainly the first generation ones, certainly increase the risk of diabetes. And there's been variable reports for others. Zidovudine quite consistently reported to be associated with increased risk. Stavudine, efavirenz, also in this South African cohort study. But in general, it's felt that the current regimens in use have minimal effect. So prevention of diabetes. How can you prevent diabetes in your cohort in front of you in clinic who have HIV and they don't have diabetes? This is actually a general slide talking about prevention of diabetes in the general population. So as usual, we're having to just extrapolate that into the HIV population. And you have the non-modifiable risk factors. You can't do anything about that for your patient, which includes their family history, their age, their ethnicity, and whether or not they had gestational diabetes, which is where you're temporarily diabetic when you're pregnant. But there's some modifiable risk factors we can do something about: physical inactivity, high body fat, high blood pressure, high cholesterol. And the relationship between high blood pressure and high cholesterol and the development of diabetes is difficult because of the cycle of risk factors and how they interact. But certainly we can do our best in clinic to modify these. Testing for diabetes. You can diagnose it 3 different ways. A lot of the world is using the HbA1c, which measures the proportion of hemoglobin in the blood, which is glycated. If it's above 6.5%, all of us sitting here, if we're not diabetic, it ought to be less than 6. If it's above 6.5, you can make a diagnosis of diabetes. And the nice thing about this test is it's a one-off, because it represents the past month, the life of that hemoglobin, and the patient doesn't have to be fasted. So it's very convenient, but it's a bit more expensive. Fasting glucose is actually a gold standard. So if your fasting glucose is above 126 twice, that means you're diabetic. And if in doubt, you can also do an oral glucose load. In fact, in people with HIV, the HbA1c, that's the one-off test, may not be the best test. It can underestimate glycemia for a number of reasons. People, partly because of drugs, can have an increase in their red blood cell size. Abacavir can change this. And the HbA1c can also be affected by lower CD4 counts. So actually, in the HIV-positive population, using fasting blood glucose, so 2 different occasions, it remains the gold standard. And I believe that's what we're still doing in the HIV-NAT clinic. So what can you do with your patient with HIV who's been diagnosed with diabetes? I think because we see this increased rate of cardiovascular disease, this association, which may be due to other lifestyle factors like smoking, in people with HIV, if they've also got diabetes, you need to work extra hard. And as we all know, it doesn't always work just to say to people you need to eat more healthily. It certainly doesn't work in the UK. And I think you have to be quite specific with people, because people can have quite odd ideas about a healthy diet. And one of the biggest problems is drinking your calories. So having fizzy drinks like Coca-Cola with sugar in them is a major problem. And a lot of your patients, you ask them, do you drink a lot of soda? Do you have a lot of sugary drinks? Ask them, and if they say yes, it might be just by cutting that out, they can make a difference to their weight. I actually used to say in the clinic here, I used to ask people about their diet, and I used to say, do you eat much Western food, McDonald's, takeaways? And if they did, I'd say, try to eat the traditional Thai food, but also watch how much sugar you're putting in your cooking, because my understanding is quite a lot of people add quite a lot of sugar to food here. But it's very difficult. Likewise, exercise is difficult as well. So the guidelines are you should try and get your patients to exercise 5 times a week for 30 minutes, and that can just be walking. But that's difficult as well, particularly around Songkran when it's very hot. Stopping smoking, yes, you need to nag them about that. And stopping smoking is apparently one of the most cost-effective things a healthcare worker can say to their patient in front of them. As a doctor, with a patient in front of me, I think, oh no, I'm going to have to mention smoking. And you just feel like a nag, you just feel like a nasty person. But it's free, the words that come out your mouth, they're not costing anything. And you never know, it might make a difference. So nag them about their smoking. And then medically, you have to aggressively manage the blood pressure. Are they on a statin? Watch their renal function really carefully because of these increased rates of renal dysfunction. Foot care. So they should ideally have their feet screened every 6 months. How is the sensation? How is the blood supply? Are they looking after their feet? Do they have foot breakdown? Eye screening once a year to prevent blindness. And have a look at their ART and think about the optimal regimen for the person in front of you. Choosing a drug is important to manage the diabetes. So usually when you diagnose diabetes, you try the dreaded diet management. So you say, okay, I'm not going to give you a medicine, let's try your diet for 6 months. And it often doesn't work. And I meet a lot of patients in the UK and I say, have you got diabetes? And they say, oh, I think I had it once, but I think it went away. And you test them and they've got raging diabetes. And quite often people just forget about it. So a lot of the time people need to go on to therapy, and metformin is recommended as the first-line therapy. This drug can interact with dolutegravir. Another drug option is sulfonylureas, and then the glitazones have interactions as well. And most of the interactions, they just mean watch the sugars, is usually what they mean. All the newer diabetes drugs, known as a class as incretins, they can interact with the ARTs, so look them up, get your pharmacist to check the drug interactions. Usually, the problem is adjusting the dose of the diabetes drug, or just closer monitoring of their glucose levels. And some people need insulin. So we believe in diabetes that if you intervene early, you prevent comorbidity. These pretty pictures are extracted from a booklet produced in Thailand by Novo Nordisk, drug company. And the top figure shows in A that if you have uncontrolled blood glucose, you have first major complications around 66 years of age, minor ones at 60, and death on average at 68. And if you give people enhanced treatment to try to bring down their HbA1c, you can improve that. And if you diagnose their diabetes early, you can improve that even further. This data is not in people with HIV. And then the graph below shows data for Thailand, again, not in people with HIV, but in people with diabetes, showing what proportion of Thai adults with diabetes reach the target of having a glycated hemoglobin and HbA1c less than 7, which is the target for people with diabetes, and it's low. So it's 41% in people who've had diabetes for about 5 years, falling down to 27% in people who've had it for 13 years. So we're struggling. And I want to talk a bit in detail about metformin. So this is a drug that is recommended now by the American Diabetes Association as the first-line drug for treatment in diabetes. And that's because of a number of studies showing that people with diabetes on metformin live longer and have less cardiovascular events. And that's been adopted by the UK NICE guidelines and also by the Thai Diabetes Association. However, this is very much thinking about cardiovascular disease and based on data in America and Europe. And there's actually been no specific promotion of metformin in WHO guidelines, for example. They just say treat with an anti-glycemic agent. And this nice booklet produced by Novo Nordisk, which I read, which is 50 pages long and is full of very pretty pictures, some of which I nicked for this talk. I couldn't find any mention of metformin, so I used the find function. And sure enough, it literally wasn't mentioned, and they talked about other drugs, and metformin's a bit of an older drug, so it's kind of out of fashion, but I believe it's a good drug. And this is an interesting study from Denmark, and this looked at people with diabetes and compared how likely they were to get an infection if they're on metformin versus if they're on other diabetes drugs. So the blue dots there represent the hazard ratio for people taking sulfonylureas, another class of diabetes drug, versus metformin. And you can see they're slightly more likely to get infection. And the red compares people taking insulin with metformin, and they're a lot more likely to get an infection. So this is supporting evidence, although far from being proof. You need a prospective longitudinal randomized controlled trial to look at this, that metformin may be protective against infection in people with diabetes. And more interestingly, this was a study in Singapore, and it looked at people at the time of diagnosis who also had diabetes, and it looked at their therapy. Again, the populations are not randomized, so it's only observational with all the limits to that. But interestingly, they found that if you were diagnosed with TB and you're on metformin, you did better. And so this suggests that metformin may have some benefits against infection. And certainly my own data, looking at patients coming into hospital in Ubon Ratchathani with melioidosis, I found that people on metformin were much, much less likely to die compared to people who weren't on metformin. So I believe that there's a potential role for metformin in T-cell effector function, and there's some theory behind it. It may be that the metabolic dysfunction in type 2 diabetes leads to poor effector and memory function of your T cells, And the mechanism of action is the activation of the metabolic regulator AMP, activated protein kinase, which is what metformin does, and that promotes glycolysis and a better, more efficient, effective T-cell response. And so I believe, and some ongoing research of mine is looking at whether people with diabetes in low and middle income countries should take metformin as first line, not only to prevent cardiovascular disease, but also to reduce their infection risk. And that what we're now seeing, because of the explosion of diabetes, we need to think about not just what diabetes means for the interaction, for the association with cardiovascular disease, but also what it means for interacting with all the big infections like TB, malaria, and other infections. So in conclusion, there is an association seen between HIV, ART, and diabetes, but whether it's causal and the mechanisms are unknown. Diabetes is certainly accelerating rapidly, and for people with both HIV and diabetes, clinicians need to aggressively manage their cardiovascular risk factors and monitor their renal function tightly. And there's a number of key research questions which need to be addressed by the HIV community. Can we predict the burden of disease? Can we prevent development of diabetes in people with HIV? What's the best drug therapy for diabetes? And in particular, is there any role for aspirin, which was proposed by one study? So I'd like to thank everybody who helped with the study, which includes Susanna Trumseng, or Dear, who now works at HIV-NAT. She used to work for me in UBAN. So thank you very much.